So today we'll be talking about blood hemostasis and how when you get a cut, you're able to limit that blood loss and not bleed out and clot where you need to clot. So there are 5 main steps involved in blood clotting. The first is vascular spasm, and that's important because when you get a cut in the skin, you want to limit that blood loss, so you want to contract and vasoconstrict the smooth muscle to make sure you're not losing as much blood. The second step is platelet aggregation and weak platelet plug formation, and that's calling other platelets to the site and creating that weak clot around the cut. The third step is a coagulation cascade. The fourth step is clot retraction and repair. And the fifth step is fibrinolysis. So that is just resolving the issue. So there are two main players in clotting. There's platelets and there's clotting factors, and they play a primary role in certain steps over others. So for the first 2 steps, vascular spasm and platelet aggregation and weak platelet plug formation, platelets are the main driver in those. However, for the second 2 steps, the coagulation cascade and the clot retraction and repair, clotting factors are the main driver in those. And to dive deeper into hemostasis, there's primary hemostasis and there's secondary hemostasis. And this is important because you have certain tests that assess certain areas of this pathway. So vascular spasm and platelet aggregation and weak platelet plug formation, which is the first 2 steps, are primary hemostasis. The second 2 steps are secondary hemostasis, and then fibrinolysis is neither. It's really there just to repair, and it breaks the clot into smaller pieces so it doesn't get lodged anywhere. So you aren't at risk for a heart attack or a stroke or anything like that. And like I said, it's important to know primary versus secondary because there are certain tests that are specific to certain primary or secondary. So the 4 tests that are normally ran to assess blood clotting is platelet count, bleeding time, PT, and PTT. Platelet count and bleeding time are very specific to primary hemostasis, and PT and PTT are very specific to secondary hemostasis. So normally all 4 tests are ran no matter what because it can be hard to find the exact issue. So they just run all 4 tests and then dive deeper and see specifically where the issue is occurring. So yeah, we'll dive a little deeper into that. So I have already drew out the full pathway. Over here I have what's normally occurring when there's no blood clotting. And then starting over here, I have what occurs when you have a cut in the skin and you need to clot your blood, starting with vascular spasm. However, to fully begin, I'll start with what's at the top. So at the very top, you have these neurons. They're known as nociceptors, and they release pain signals. And then the second layer I have is smooth muscle, and obviously your blood vessels need smooth muscle because they have to adapt to environmental changes, pH changes. So they need to either vasodilate, vasoconstrict the first thing I can think of is when it's cold outside. You want to keep that warmth in. So your blood vessels are going to narrow. They're going to vasoconstrict so you can limit your heat loss. However, when it's hot outside, you need your blood vessels to vasoconstrict to get rid of that heat to cool yourself off. So their smooth muscle is needed for the changes in diameter of your blood vessels. The third layer I have is collagen, and it's needed for elasticity, flexibility. Your blood vessels, blood is pumping through them. They need to be able to be accustomed to changing blood flow. So they need to be flexible. And then the last layer is these endothelial cells, and those line the blood vessels and are important in many and release many things needed for this pathway. So where we will start off is normal. There's no cut, there's no clotting. So, like I said before, there's two main players that play a role in clotting: platelets and clotting factors. So when you don't have a cut, you need to inhibit these. So we will discuss how you inhibit these. So first and foremost, specifically for platelets, to inhibit them, you have nitric oxide released from the endothelial cells. You also have PGI2 that's on the surface, and these both inhibit platelets. Just drop my thing. Sorry. And then specifically for clotting factors, you have heparin sulfate that's located on the surface, and it binds to antithrombin, and then thrombomodulin, and these all inhibit clotting factors. So these are what happen when you don't need to clot your blood. So these are, because obviously you have platelets and you have clotting factors always flowing through the blood. However, they're turned off because of these right here. So they're not activated, they're not binding, they're not sticking to anything, they're just flowing through. So the first step of clotting, like I said before, was vascular spasm. And there's 4 ways of vascular spasm. However, only 3 occur in the actual vascular spasm stage. The 4th one occurs in platelet aggregation and weak platelet plug formation. So we'll discuss the first 3 ways here. So when you have a cut that only goes through the endothelial cell and through the collagen layer, your endothelial cells release endothelin, which goes to the smooth muscle, causing it to contract. And then, however, if you have a cut that goes through the endothelial cells, through the collagen layer, and to the smooth muscle, then nothing is actually released. The muscle just contracts, and that's called myogenic. So it goes directly to the muscle that the tear is occurring. And then the third way is obviously when you have a tear, there's a lot of inflammatory molecules that are released. So what happens is they go up and bind to these nociceptors, and this triggers a pain response. And then from those nociceptors, they talk to the smooth muscle and also lead to contraction. So you have pain release, pain signals released, and then your muscles are contracting, which you want because you want to limit the amount of blood that's lost. So you want your blood vessels to become more narrow. Okay, so that's the first stage of blood clotting. And then the second stage is platelet aggregation and weak platelet plug formation. So platelet aggregation, like we discussed, is calling other platelets to the site so you can clot and create a weak clot around that cut. So not only do platelets need to get turned on, but they also need to get told where to go. So how they get turned on is nitric oxide doesn't get released, PGI2 is not at the surface, and then as well as told where to go, that is specific to von Willebrand factor. And that tells the platelets exactly where to bind. So you have a cut, your endothelial cells release a protein, like I said before, called the von Willebrand factor, and that tells the platelets, hey, bind here. So your platelets have a receptor called GP1B, and that allows the binding to the von Willebrand factor and starts that the platelet plug formation. So obviously you need more platelets. You can't just have 2 to fully stop the bleeding. So you got to call the other platelets. So when your platelets are bound, like these first couple platelets are bound to the von Willebrand factor, they release 3 things: ADP, TXA2, and serotonin. what's important for ADP and TXA2 is they are the ones who do platelet aggregation. They call those other platelets to that site. However, TXA2 and serotonin, this, like I said, they go back to the smooth muscle and cause contraction. So that is the fourth way of vascular spasm that I talked about before was going to be leading over into this second step. So that is the fourth way of vascular spasm. Okay. And then, so as of right now, you're not able to see this von Willebrand factor anymore. So platelets will now have to bind to other platelets. And how do they do that? Well, all platelets have a receptor called GP2B3A, and that allows them to attach together through the molecule called fibrinogen. So now they're able to stick together and form that weak platelet plug, that weak clot around the area. So the platelets are on, but they're not very tight. So that's what the coagulation cascade, that's what creates that tighter mesh around the platelets. So, like I said, these first two steps, this is primary hemostasis. This is the first two steps, and platelets are the primary driver in these two steps. What we're going to discuss next in the coagulation cascade, that is where we start secondary hemostasis, and that is where clotting factors are the primary driver in these. Okay, so we'll start here. Let me see. So right here, this weak platelet plug formation is creating a negative charge due to something called, I'm about to butcher this word, but it's okay, phosphatidylserine. That creates that negative charge around the plug, and that negative charge is what activates clotting factor. So you need that negative charge around the weak platelet plug to activate clotting factors and enter in this pathway. So that negative charge allows clotting factor 12 to turn into 12A, and then 12A turns 11 into 11A, and then 11A turns 9 into 9A, which binds to 8 with the help of calcium. And then that allows 10 to get turned into 10A, which binds to 5 with the help of calcium, which causes 2 to get turned into 2A. And then 2 is prothrombin, 2A is thrombin, and we can see that because we've heard thrombin, familiar with clotting factors up here. And then 2A has two things it can do. It can convert 1 to 1A, and 1 is fibrinogen, and then 1A is fibrin. So what happens is fibrin takes those single fibrinogen molecules and it attaches them to it's like a string. And ultimately what this does is it slows the blood down. And then 2A also has another thing it can do. It can turn 13 into 13A. And this leads to cross-linking. So it takes those fibrin, I kind of drew it over here. So this is fibrin, and then the little molecules are fibrinogen. So it takes these fibrin strands and it crosses them to form a fibrin mesh around the clot. So it kind of just creates like a tighter, more stable clot. So now I'm going to get into kind of the nitty-gritty of it. So the first part of the cascade right here from 12 to around like 8, that's called the intrinsic pathway. And like we discussed before, there's a certain test that is assessed for the intrinsic pathway, which is PTT. So that's specialized to that. However, there's another cascade that occurs over here called the extrinsic pathway. And what tests for that? That's the PT test. PT. Okay. And what happens over here is, so directly on the endothelial cells, clotting factor 3 will be put on the surface. And clotting factor 3 isn't just running around the blood. It is only there when there is a cut on when there's a cut, and then it gets put on the surface of those endothelial cells. So what it does though is it turns 7 into 7A, and then 7A can then go and activate 10. So from 3 to 7, that's known as the extrinsic pathway. So then you're probably like, well, what's all this in between? Is it intrinsic, extrinsic? Like, how do you test that? So that's known as the common pathway, and it affects both PT and PTT. PTT, yes. So say there's an issue with clotting factor 11 that only affects the intrinsic pathway, and it only affects PTT levels. So the time will be higher, so your PTT will be higher. Has nothing to do with your PT, because that's a whole nother pathway over here. However, and same thing if there was a problem with 7, that's only affecting your extrinsic pathway. It has nothing to do with your intrinsic, so your PTT would be fine. However, if there's a mutation or a problem anywhere from 10 to 1 or 13, then that's known as the common pathway. It's affecting both PT and PTT. So you're going to have high levels of both. The time is going to be higher for both. So that was probably the most dense part of this, of the clotting steps. But that is very important for blood clotting. The next step is just clot retraction and repair. So for clot retraction, you're trying to pull both sides of the cut together. And then for the repair part, you're trying to put more cells in that break. And how do you do this? You do this through mitosis. So you have something known as PDGF, and it tells the smooth muscles to enter mitosis. You also want your endothelial cells to do mitosis as well and create more cells to fill in that space. So you do that through VEGF, which tells those endothelial cells to enter mitosis. So then you're filling in that cut, you're filling in that space. So those two steps are secondary hemostasis. Those mostly involve clotting factors. The last step of blood clotting that we're going to be talking about is neither. It's just resolving the issue, like I said before. So you don't always want to have that clot there. You want to get rid of it at some point. So this is how you get rid of the clot. So your endothelial cells release something known as, or produce something known as TPA. TPA takes plasminogen and activates it into plasmin. Plasmin is like a Pac-Man. It takes that clot and it destroys it into tiny pieces. Because like I said before, you don't just want to release that big clot into the blood, because then you could have a stroke or you could have a heart attack. Like, you want to make sure it gets cut down into smaller pieces. So after that plasmin takes it and destroys it, two things are released in the blood. You see fibrin, which makes sense because around that clot is a fibrin mesh. So when you're breaking it down, obviously you're going to have some fibrin in the blood. And then you'll also see D-dimer, which if you see people who have a lot of clots, you'll see a lot of D-dimer in their blood. And so that could play a role in how blood clotting as well. So that was the full outline of what goes on in blood clotting. So now we will be talking about certain drugs affecting certain pathways or certain areas of this pathway. So I'll probably go back and forth between the certain drug and then the pathway to show directly where it's hitting and what's going to happen because of it hitting that certain area. Because like I said, it can hit primary hemostasis or it can hit secondary hemostasis. And how does it affect platelet count? And how does it affect bleeding time? Because we know certain tests are specific to certain areas of hemostasis. So bleeding time and platelet count are specific to primary hemostasis, and PT and PTT are specific to secondary hemostasis. So we'll just dive a little deeper into that. So the first drug we have is blood thinners. So we're kind of just gonna discuss where it targets and then how it's going to affect platelet count, bleeding time, PTT, and PT. So blood thinners enhance antithrombin activity. And where have we seen antithrombin? Well, we saw it in the normal, what happens normally when there's no clotting. So if we're enhancing that, we're destroying all clotting factors, not just one specifically, but all of them, because you're inhibiting all of them. So this affects primarily secondary hemostasis, so platelet count, totally normal. It's not affecting platelets at all. Bleeding time, that's specific to the primary hemostasis, and you're not targeting that. You're targeting secondary, because that's where clotting factors are. PTT and PT, that they both are going to be increased because you're not just targeting 12, which can be assessed with PTT, or 7, which can be assessed with PT. You're targeting all of them. So both times are going to be up. So you're destroying everything, all of the clotting factors. So the next one is clopidogrel, and it is a ADP inhibitor. Where do we see ADP in the pathway? We saw it being released by platelets that were bound to the Van Willebrand factor. And what was its job? Its job was to call other platelets to that site to create that weak platelet plug formation. So how is this going to affect platelet count? It's not. It only affects what's released out of it. It's not actually affecting the count. So the only thing different is the platelets just aren't releasing ADP. Bleeding time, it will be increased because this is involved in primary hemostasis. It's involved the platelet aggregations, calling those other platelets. So if you can't just stop bleeding with 2 platelets, you need to call others to create that clot. So your bleeding time is going to increase. This is a little tricky too, because obviously if the problem is in primary hemostasis, then how can it affect secondary hemostasis? Well, it can, and I'm going to explain how. So PTT, how is that going to be affected? It's also going to increase because, like I said before, how do clotting factors become activated? They get activated because of the negative charge around the platelet plug formation, around the weak platelet plug. If you're not even forming that weak platelet plug, there's no negative charge, so they're not becoming activated. So this whole intrinsic pathway is just not occurring. However, for PT, it's its own little pathway. It's actually, like I said, it doesn't even become activated because it has nothing to do with the platelet plug. It becomes activated because it sees the cut and then it gets put on the surface. So its PT levels are completely normal. Okay. The next drug is aspirin, which is a GP2B3A inhibitor. Where do we see that? We saw that in primary hemostasis, specifically in platelet aggregation and weak platelet plug formation. And it is the receptors on the platelets that allow them to attach together to form that platelet plug. Since they're not able to see the Van Willebrand factor anymore, they bind to each other to form that clot. So if you don't have that, then you can't form that weak plug. So what does that do for platelet count? So this one is a little strange too, because normally if it's something that's specific to platelets, like GP2B3A, that's specific to platelets, you would think that it would affect platelet counts. It actually doesn't. So platelet counts are normal, but in most cases, like there's GP1B, which is the receptor that binds to the von Willebrand factor. If those levels were down, then that would affect platelet counts. So most of the time, if it's specific to platelets and it's lower levels, it's going to affect the count. But GP2B3A is the outlier. It's one that even if it's inhibited or not there, it's not going to affect platelet count. However, bleeding time is going to be increased because you don't have those platelets being called over to help clot and prevent blood loss. So your bleeding time is going to be up. And then we jump over to PTT. Again, you don't have those other platelets creating that negative charge, so your clotting factors over here are not becoming activated, so this pathway doesn't occur. So this is kind of similar to the other one that we had discussed. However, with PT, levels are normal because, like I said, it's not reliant on the negative charge associated with that platelet plug. It's fully put on the surface from the cut. So it doesn't play a role in or rely on the primary hemostasis, unlike PTT, which relies on that platelet aggregation and platelet plug formation to become activated. The last one is Pradaxa, which is factor II inhibitor. So, unlike blood thinners, which we saw up here was enhances the antithrombin activity and affected all clotting factors, Pradaxa primarily affects clotting factor II, so it's specific. So this is occurring in secondary hemostasis, so it has nothing to do with platelets or anything like that. So platelet count, completely normal, it doesn't affect them at all. Bleeding time is also normal because that's primary hemostasis, and the issue is occurring in secondary hemostasis, specifically the coagulation cascade. So now we're going to look at PTT and PT. PTT will be elevated, but so will PT. Well, why? Because 2 is in the common pathway. So they're both times, and it will be increased because it's not only specific to PT and it's not only specific to PTT or the intrinsic or extrinsic pathway. It's in the common pathway, so it's affecting both of them. So those were all the drugs that were listed, and it's easy to just go back to the pathway, see what it's inhibiting or enhancing, and then what will happen, like what the results would be on a test, like the board test that we had. So clotting is very important, obviously, because you want to limit the amount of blood that you're losing. And then just knowing this pathway can help, especially there's many diseases associated with blood clotting. So knowing what potential areas could be targeted and then how to start with the bigger picture and kind of dive deeper into each one can help you not only diagnose but find treatments as well. So yeah, that was my lecture on blood hemostasis.